Luann,
Hello.
Dr. Weiss, it's good to see you again.
Good to see you.
And we have already gone through your history and physical, and we've gone through your tests, and with all of that, including this one, which is the EMG test, which was negative, we decided that you are a good candidate for doing the bilateral fixation,
Yes.
SI joint fixation. That should
Yes.
help you a great deal. That you don't need the fusion, and that we don't need to do a piriformis release. So I think we're ready to go ahead and proceed with that if you're ready.
Okay, well, I have done a little bit of studying upon this, and I've got some questions. I wrote some questions down, and I would like you to, if you could explain the surgery to me, exactly what I will be going through and what you'll be doing to me.
Sure. The first thing that we're going to do is the morning of the surgery, you're going to go to the preoperative area. And in the preoperative area, Vicki comes in the morning of the surgery, as well as I do too, of course. But she is going to manipulate you and make sure that you feel good and that you're in alignment, in good alignment. You know yourself by the history, there are times when you feel out and you feel in. We want to make sure that you feel in at the time of surgery. And so by talking to you and by manipulating you at that time in the pre-op area, we assure that. Then you're going to be taken to the surgery suite itself, and you'll be on the gurney in the surgery suite, and we will put you to sleep there. You also get IV antibiotics at that time, and at that time they'll set you up for the neuromuscular monitoring. They'll put little needles, and they are little, and of course, and you're asleep also anyway, but they'll put small needles in all the muscles so that during the surgery we can monitor that to make sure we're not near a nerve root. And then after that we will roll you into a prone position. The surgery is done with you on your stomach, so you'll be on chest rolls. We'll roll you because we think that you're in good alignment, and we've already done that while you're awake. Actually, we'll roll you over like we roll people who have thoracolumbar fractures or things of that sort. You know, it's kind of a log roll to make sure we don't twist you. Once we've got you on the chest rolls, then I'll make sure that, and to my satisfaction, that you're in good alignment, and then Vicki will make sure to her satisfaction that you're in good alignment still. Then we're ready. And then we'll go ahead and prep your back and proceed with surgery. I do want to show you that. This is a spine, and this is the pelvis down in the bottom. This is, of course, with you lying on your back. And then I'm going to get my pin out here. This is the SI joint as viewed from the front. This is the ilium, and this is the sacrum, and then you have the other one over on that side. Symphysis pubis here, but we're not dealing with that. We will turn you over into a prone position like this, and that's the way the surgery is done. And on the back side, this is the SI joint, the sacrum, the ilium, and again on the other side there. Now you're having a fixation only, and what we will end up doing is putting 2 screws on each side. And the way that I determine where to put the screw in is first with an 18-gauge needle and then under the C-arm. I didn't mention earlier, of course, we have you on position so that we can use C-arm, which is for x-rays, for fluoroscopy, so that we can look through and see the bones. And then using the needle, we'll determine where I want to make my small skin incision. And we just make a very small incision, enough so that we can get a guide pin in. So we'll use the guide pin, which is pretty long. It's about this long or so. It doesn't, all that does not go in you, but that way so we have adequate length. And we'll advance that from the outside through both bones of the ilium, across the SI joint, and into the sacrum. Usually go in about 40 millimeters or so, or about 1.5 inches. Now, at that point, we'll test it for any nerve root stimulation, or make sure, in other words, that we're not near a nerve root. We'll stimulate the pin, and then we'll see if we get a response from the muscles. And if we do not get a response, we stimulate up to 20 milliamp level. If we do not get a response at about 50 milliamp level, we're usually very happy with that, even if we get a little response later on. But that makes sure that we're not close to the nerve roots, which are down here. Now, after we have the pin and the pin, we're happy with that, with the positioning on x-ray, as well as with the lack of response on the stimulation. Then we'll get a screw, a titanium cannulated screw, and put that over that guide pin, and then literally put it into the bone, screw it into the bone and compress it. So, and then after we have the screw in, and usually I'll use 35 millimeter length screws most of the time. After we have the screw in, we'll test it again by stimulation to see if there's response from the muscles. And again, if there isn't, then we're happy with that. And then that's the first
Do you ever have to reposition a pin or
We
move a
do.
pin out?
Sometimes if we start getting response about 10 milliamps or below that, we're certainly going to reposition
Okay.
it. Generally, again, we like to have 50 milliamps without much of a response. But yes, sometimes we do
Okay.
reposition it. You don't have to, of course, we don't want to be touching a nerve root or certainly not injuring a nerve root, but you will get a response even if you're close to the nerve root. You don't have to be touching it to get a response because it goes through the bone. So we're happy with the first one, and then we put in a second one, which is essentially parallel, usually a little bit higher, pretty much parallel to the first one, a little bit off from being parallel, but very close. And then come over and do the same thing on the other side.
Okay.
And then take out the guide pins, and we just put one suture in each of the stab wounds. You just have really 4, 2 on each side of the stab wounds, and they're just little tiny incisions like that. I should say incisions says stab wounds. Patient told me that one time. But and then suture that, and that's actually the end of the procedure.
Well, now, after this, how long am I going to be in the hospital?
You'll be in the hospital if you're local. We'll keep you overnight.
Okay. Okay. Now, what about my short-term restrictions right after surgery?
In the immediate period after the surgery now, we are going to limit your activity. We do want you to be active. We do want you to walk.
Okay.
But we want you to limit the prolonged standing or limit the prolonged walking to about 30 minutes.
Okay.
And then as far as sitting, of course, you're going to be sitting a little bit longer, but we want you to limit the sitting or riding in a car to about an hour. And in the immediate period, really, you don't want you really to pick up more than 10 pounds. You have to be careful going up and down steps in particular.
Can you go up in that all, or like once a day?
You
Or?
can.
Okay.
You really will let you do what you really need to do.
Okay.
But just kind of be careful in doing it.
Okay.
The other thing we want you to not do is do any repetitive bending over, repetitive extending,
Okay.
which is really similar to most back problems.
Now, what about my long-term restrictions?
Long term, as we talked about before, no bungee jumping.
I
things like
promise
that.
not to.
Okay. And then, but more significantly, even you don't want to do things that are going to be jarring to the back. Specifically, even stair climbing or not stair climbing, but the stair master type of
Okay.
aerobic exercises. It would not do that. I think swimming would be much better.
What about yoga? Because I've done yoga for years.
Yoga, if you avoid the extremes of it, you can do the yoga. think
I don't
yoga
do
would be
the
fine.
extremes of it. My body won't do the extremes of it. What about, I was curious about the screws. Do they ever work their way out?
No, they don't. There is a possibility they could possibly become loose, but really we've not had that problem either. The screws are made of titanium, and the titanium really attracts the bone to grow right up to it, much more so than stainless steel. So they're not going to work their way out on their own.
Now, is there a difference between a fixation and a fusion?
There is a difference. You're just going to have the fixation.
Okay.
And usually if you have not had the problem for continuously for a prolonged period of time, you have periods of time where you're pain-free or we can make you pain-free, and if you don't have any demonstrated arthritis of the SI joint, we will just do the fixation, which is what you were going to have. But the fusion, let me show you again. But in some cases, we do the fusion. Now, the fusion does involve an incision, which is going to be right over the SI joint and the iliac crest right here, roughly from about here to here. Then we have to come down through the ligaments down to the SI joint here, and then scrape out part of the bone, or at least part of the joint surface on each side. Then take part of this bone, I usually take part of this bone in the back as a graft and put that into the joint. But then we still go and use the fixation and put the screws in for the fixation as well. But that's the fusion and the fixation.
Oh, okay. Okay.
Now, obviously, if you do have the fusion, you're going to have a little bit more pain than if you just have the fixation. In our experience, the fixations alone have done very well for the vast majority of people. But even if you do have the fusion here, the fusion of the SI joint, in my experience, does not hurt nearly as much or nearly to the degree as do the fusions of the back, the fixation and fusions of the back, which really are much more painful. So this is not on the scale at all of having discomfort from a traditional back fusion.
Oh, that's good. That's
So-
good to know.
So these are really two different things.
That is, now, the other thing, when you fix the joint, which it's not moving anymore, do I lose any motion, or is my body going to be able to tell that?
Of course, the whole idea of this whole procedure is to limit what I call micromotion, which in this case you always are supposed to have a little micromotion in that joint. But if you have excessive motion, it leads to the problems like you have. So we are limiting that motion. We are, but even limiting that motion, it's not going to affect you at all as far as your overall motion. You're not going to feel anything as far as a limitation of motion of what you're thinking of as far as bending, stooping, twisting.
So I can continue on what afterwards.
You can continue to actually do a lot better because it's not going to hurt you.
Exactly. That is true. That's true. Now, speaking of pain, what about post-op pain? How much pain is involved with this?
You are going to have some discomfort, especially in the immediate post-op, but it is it's a post-operative pain. It's not the same pain as what you had beforehand.
Okay.
And usually is not that severe that you cannot get up on the morning or on the afternoon after the surgery. We usually do these surgeries first thing in the morning so that we can do it this way and so that Vicki is available to come in the OR as well. And then by the afternoon, usually we try to get you up with physical therapy. And most everyone responds that most of their preoperative pain is gone, if not all of it. But they still have some of the postoperative pain, but it's much more tolerable for them than the preoperative pain was. And of course, that's going to lessen. Even by the next morning, that's markedly lessened.
What about the risks of this surgery?
Well, it is surgery, and there are always certain inherent risks. Probably the biggest risk to this procedure is that is to the nerve roots. You want to make sure that you don't injure the nerve root or come close to irritating the nerve root with one of the screws. So, and that's why we do the neuromuscular monitoring, and that pretty well ensures that we're not in the vicinity of the nerve root. So that's the first thing. The second thing is we want to make sure that you're in good alignment, so that when we fix you, that we're fixing you in good alignment, and that's why we manipulate you beforehand. And why Vicki makes sure, not just beforehand, but also on the table, that you're in good alignment at the time that we fix it. As in all surgery, there's always potential of a problem with infection. We've never had any, but with the infection, so we give you preoperative antibiotics. We give you SCD hose to make it a lot less likely that you're going to have any problems with deep vein thrombosis and throwing blood clots. We've not had that problem either, but that's potentially there. There are the general problems of anesthesia. Anytime you're put to sleep, you could develop pneumonia, you could have other things like that. But really, anesthesia today is so much better than it was. You know, everything's monitored by pulse oximeter to make sure you're getting good oxygenation. The drugs are so much better than they were years ago that is not a problem. This is not that long of surgery. Probably the biggest thing would be that you may not have complete relief of all of your pain, and that I would some people have complete relief, but not everyone does. But on almost all cases, this greatly improves your pain.
Well, anything would be an improvement. I am ready to have this surgery. You've answered my questions, and I think let's just go for it because I am very ready.
That sounds good.
Thanks a lot, Dr. Weiss. Thank you very much.
You're welcome.
See you in surgery.